This presentation is going to talk about EKGs and being able to look at the blood flow through the heart, the electrical conductivity of the heart, and then look at the waveform, the different waves, the different segments and intervals, and also some of the EKG patterns that you need to be familiar with. So, first thing is that we need to talk about the blood flow through the heart. So it starts at the superior vena cava, bringing the blood from the top of the body into the right atrium. And right here is the inferior vena cava, bringing the blood back to the heart from the lower portion of the body. So it goes from the vena cava into the right atrium. From there, it goes through the tricuspid valve. From the tricuspid valve, it goes into the right ventricle. It then is going to go off to the lungs and be oxygenated. So it's got to go through another valve, and that's the pulmonary semilunar valve. It's going to go through the pulmonary arteries, because remember, arteries take blood away from the heart. It's going to go to the lungs to get oxygenated, and then the blood is going to come back to the heart through the pulmonary veins. From there, it's going to go into the left atrium, through the bicuspid valve or mitral valve, into the left ventricle. It will then travel through the aortic semilunar valve, and then go out through the aortic arch, or as it goes down through the back, it's called the descending aorta. Now, a couple things that help to remember the blood flow. The valves, you always try before you buy. And so think of that. The right side is going to be try, the left side is going to be buy. In addition, it's always chamber, valve, chamber, valve. So it's got to be the right atrium, a valve, the right ventricle, a valve, and the same way on the left side. So as long as you remember the right side of the heart is first, the left side is the second half where the oxygenated blood goes through, you know you're going to have the right atrium, the right ventricle, the left atrium, the left ventricle, and you're just going to have to remember those valves. The tri is before the bi. This is going off to the lungs, so this is going to be the pulmonary semilunar valve, and this blood is going to be going off to the aorta, so this will be the aortic semilunar valve. Okay, just a different picture. It kind of shows and talks about that, if that's a little bit easier for you to look at. In addition to the blood flow through the heart, we have to be able to look at the conduction system of the heart, because that's what's going to give us the EKG pattern that we see. And so we're going to look at the beginning, which is the SA node, and that's going to sit right at the top of the atrium, and it's sinoatrial node. It is going to be innervated, and it is going to send an impulse down to the AV node. Now, the SA node is also known as the natural pacemaker of the heart, because this is what's actually setting the heart rate. So as the nerves, as that transfers down to the AV node, it's going to trigger, and then that's going to go down through the bundle of His. It will then branch into the left and right bundle branches, and then the Purkinje fibers are going to innervate those nerves all around the heart. So again, this is going to trigger the contraction of the atria as it goes to the AV node and down through the bundle of His. This is going to help the contraction of the ventricles all the way down through these Purkinje fibers. So when we look at the cardiac cycle, one complete heartbeat is that AV node to the, SA node to the AV node, down through the bundle of His, the Purkinje fibers, and out to the rest of the heart. Okay? So when we look at the EKG cycle, I'm not sure what it means page 156. So just ignore that because I don't remember what that's for. But this is where we're going to be able to see the actual components of when the atria actually contract, when they relax, when the ventricles contract and then relax, and then the heart kind of resets itself. So in looking at this, we're going to just, and we'll talk about each one of these separately. The P wave is the first wave. It should be an upward deflection, which means it's up rather than being a downward deflection, or so it's always going to be a bump up. We then have a PR segment. Now, little hint, a segment is between two waves. Intervals actually include the wave. So the PR segment is at the end of the P wave and before the QRS. So this is the PR wave, or segment right here. The PR interval is actually from the beginning of the P wave all the way to the end of that, or the beginning of the QRS complex. QRS complex is going to be all of those. This is where we're going to see a big influx, because this is when the ventricles are contracting. The atria are actually relaxing here, but you don't see it because the contraction of the ventricles is so much larger than that relaxation. Okay, we've got the ST segment. Remember, it goes from the end of one wave to the beginning of another. We then have the T wave, which is that final positive inflection, and then here we have the U wave. Now there's a lot of times we really don't see the U wave. It's very, very minimal, so you may not see that. But we usually always see the P, QRS, and the T wave. Down here, it talks about the QT interval, and that's going to be from the beginning of the Q all the way to the end of the T. So again, we have P wave, QRS complex, the T wave, and the U wave. Segments are going to be from the end of one wave to the beginning of the next, and intervals are going to be including the wave to the end of the, or the beginning of the next wave. So we've talked about positive deflections. Here's our P wave, right? And so then we see a huge positive deflection with the QRS. This is considered a negative deflection, right? And this line here is our isoelectric line. So it's kind of the neutral point. Anything above that's going to be positive. Anything below that is going to be negative. Now, when we look at this on the EKG screen or on the monitor, if we do not have a positive deflection here in lead 2, we've got the leads on wrong. We've got the right leads on the left side and the left leads on the right side. So you need to double check that, switch them around. Remember, it's the patient's left and right, not your left and right. Okay. So again, we've talked about this P wave. This is the electrical activity associated with the contraction of the atria. It's also known as atrial depolarization. So as the atria contract, that's when it depolarizes. The QRS actually shows the electrical activity of the contraction of the ventricles. And this is known as ventricular depolarization. The first downward deflection, which is right here, is the Q wave. The top of the wave here is the R wave. And then down here again is the S wave. So what happens here? We know we have this depolarization of the atria. Well, it's got to reset itself because as it contracts, it has to relax. And that's called repolarization. So it's relaxing right in here, but because the ventricle is contracting and it's such a strong muscle contracting, we really don't see the repolarization of the atria. It's actually within this QRS wave. The T wave is actually where we see ventricular repolarization. So we see the depolarization here in the QRS, and then as the ventricles relax, it repolarizes, and we see that T wave. The U wave sometimes follows the T wave. It's very, very small. And the U wave actually is the repolarization of the bundle of His and the Purkinje fibers. So we generally aren't seeing that as a large wave. You may see it, but if you don't panic because it just may not show up on the EKG or the screen. So when we talk about the baseline, again, we're talking about the isoelectric line. If we have an upward deflection or a positive deflection, the wave is going to go up. That negative deflection is going to go down. We talked a little bit about the segments and intervals. And segments are going to be between two waves, and intervals are going to connect or include the wave plus the space between the two waves. And these are important because when the cardiologist is going to be reading the EKG, they're actually going to be looking at the length of time these segments and intervals may be, if there is an increase in one, if there could be a decrease, and those are going to indicate certain diseases or possible diagnoses for the cardiologist. Okay. So the PR segment, again, it's between two waves. It ends at the atrial depolarization and begins with the ventricular depolarization. What this is actually the time needed for the impulse to be delayed at the AV node. So we get that SA node firing, it goes to the AV node. We just need a little bit of delay there before it transfers on. Generally, our PR segment is flat. It's usually isoelectric, right on the line, and that's normally what we will see for this PR segment. The ST segment is at the end of the S wave and finishes at the start of the T wave. This is going to be the time between ventricular depolarization and the beginning of ventricular repolarization. It should be isoelectric, but if we see an elevation in that segment, so it's not flat, it actually starts on the baseline and goes up, that generally suggests that the patient may be having a myocardial infarction or a heart attack. And it's going to be, we call that a STEMI, and we'll talk about that in a little bit, that elevated ST segment. If it's depressed, if it goes down, it may suggest the presence of ischemic myocardial tissue in the ventricles. So that's why it's so important that we get a nice clear picture when we're doing an EKG so we can actually see if there's an elevation or if there's a depression in these segments. So again, our segment here, this is the PR, it's usually isoelectric, and the same way here. So if we see an increase in the ST, that's when it may be an MI. If we see a decrease before the T wave, then that may indicate some ischemia. Intervals, again, are the length of a wave with a segment. So the PR interval is actually going to be from the beginning of atrial depolarization to the beginning of ventricular depolarization. And the QT interval is going to start at the beginning of the ventricular depolarization, and it goes to the end of the repolarization of the ventricles. Oops, sorry, calendar. We then have the baseline, that's after the T or U wave, and that's that short period of time when the heart returns to normal and is resting. Now, the faster our heart rate is, the shorter that baseline will be. So again, we see the PR interval here. We see the QT interval here. Here's our ST segment. Here's our PR segment. And then we have our P wave, our QRS, our T, and possibly the U. So this is a handy dandy little chart that's really nice. That kind of just tells you what the component is, the P wave, the QRS, the segments, intervals. Tells you what you should be seeing, and then what the heart is doing. Is it depolarizing? Is it repolarizing? You know, what may be going on there. So once we've finished talking about the electrical conductivity of the heart, we actually need to be able to know how the EKG machine works and the leads. So it consists of 12 leads. So we're going to see 12 different pictures on one EKG. Okay, so we're actually taking different pictures from different angles in the heart. And that allows us to be able to see all the different issues that may be going on in the heart from really a 360-degree angle. Now, it's a 12-lead EKG, but we only use 10 electrodes. So it's a 12-lead EKG using 10 electrodes. So our limb electrodes are going to be the right arm, which is going to be RA, the left arm, which is LA, the right leg, which is RL, and that is our ground lead. So it really isn't going to show us anything, but we've got to have that lead on there to be able to ground all the other leads. Okay, it's like a reference point. And then the left leg, which would be LL. Most important thing to remember here again, it is the patient's right and left, not your right and left. The chest leads are going to be abbreviated either V or C, and there's 6 of those chest leads. Einthoven's triangle is actually an imaginary formation of 3 limb leads used in an EKG. And so we look at that, and that's going to tell us where each lead's picture is happening. So we can see that lead 1 is taking a picture from the right arm to the left arm. Lead 2 is taking a picture from the right arm down to the left leg. Lead 3 is showing from the left arm down to the left leg. Okay, those are going to be called bipolar leads. So again, we're seeing this picture for lead 1 is directly across. It's going to be reading the voltage between the right arm and the left arm. Lead 2 is going to be recording the heart's voltage between the right arm and the left leg. And lead 2 is the one that we will see the largest EKG at the very bottom. It will be a longer strip. You'll see it in the 12 lead 2. And this is the lead that we generally see on a monitor. Lead 3 is going to be recording the heart's voltage between the left arm down through the left leg. And again, these are called bipolar leads. All right, so here we go. When we look at a 12-lead EKG, here's lead 1, and we have a very short, because we need 12 snapshots. So here's lead 1, here's lead 2, Here's lead 3. We're going to go into this, but this is your AVR, AVL, and AVF. And then this other 6 remaining are the chest leads. Here's V1, V2, V3, V4, V5, and V6. This is what I was talking about before. This is going to be a long strip, and that's going to be lead 2, and that's what we will see on the very bottom of the very bottom of the EKG printout. Now, the other thing to remember is this little notch right here is our that's going to be at the very beginning of each line, and this is our quality control. We're looking at that to make sure that we know that the EKG is good. So again, it's going to be 10 high, 2 across, and then 10 down. Okay, so we talked about AVR. This is going to measure the heart's voltage between the right arm and the left arm and the left leg. So we go to the left arm and left leg, and it's going to be shooting up towards the right arm. Our AVL is going to be between the right arm and the left leg, and then shooting up towards the left arm. And then our AVF is going to be going directly between the right arm and the left arm and straight down to the left leg. V1 through 6 are going to be our chest leads, and it actually is measuring the heart's voltage from the front to the back of the heart. So we need to make sure that they are placed accurately to get a good, reliable reading. Oh, I am going to try to go back here. So I jumped ahead a little bit because I didn't have a picture of this with the lead placement, but this is going to be very important. Our V1 goes on the right side of the sternum between the 4th and 5th intercostal space. We don't want it over the bone. We need it in between the intercostal space. V2 goes directly across it on the left side of the patient. V3 is going to jump down to just above between the 5th and 6th intercostal space. V4 is going to be mid-axillary between the 5th and 6th intercostal space. 6 is going to be, nope, I said that wrong. This is mid-axillary. I'm sorry, 6 is mid-axillary. V4 is mid-clavicular. So what we're going to do is when we put the leads on, we're going to put V1 on and V2. We're going to find the intercostal space there, put 1 and 2 on. We then are going to go to 4, find mid-clavicular point, and come down in between the 5th and 6th intercostal space. We then are going to jump over to V6, which is the where we're going to, again, still between 5 and 6, but it is going to be mid-axillary. So it's underneath the armpit. Once those are in place, we're going to put the V3 lead between the F2 and the the V2 and the V4, and we will place V5 between the V4 and the V6. Okay, so now I'm going to go back here. Okay, so when we put the leads on and we try to do an EKG, there's a number of things we can see. And there's some things called artifacts that we're going to be able to see. If you see this, you're either going to be extremely worried, or you're going to see that the patient's talking to you, they're okay. This is just muscle movement. So this may be somebody who has Parkinson's, and we have to try to figure out how we can place the leads because of their tremors. What we'll do, if it's just their extremities that they're having tremors in, we may need to move the arm and leg leads to more on the bottom of the chest and the top of the chest. But we do have to document that because it is going to look a little bit different than previous EKGs. Wandering baseline, here we go. It's a nice isoelectric line, and then all of a sudden it just goes up and kind of moves all over. That means that one of our leads is not connected well, and you're going to need to go back and look to see which lead you need to replace. The 60 cycle interference. This is some type of electrical interference. So we see our QRS, but there's something going on. And now with every bit of technology we use and so many electrical instruments and things we use in the office, we see this a little bit more and more. So you might have to unplug the EKG machine and use it off the battery. You may need to look around and see what might be interfering with that. But this is definitely interference from some type of electrical source. Broken recording is when one of the lead wires is broken and you're just getting some crazy recording here. That means that it's going to actually have to be replaced. The leads will have to be replaced, and that is a very expensive venture because the leads themselves are expensive. That's why we take very good care of them. We don't roll over them with the EKG cart. We just have to be incredibly careful with those. So again, we've got placement of where these are going to be, okay, between the 4th and 5th rib. Again, 5th intercostal space between the 5th and 6th, mid-clavicular, and then mid-axillary. So this is just a written explanation of where the lead placement is. And again, that lovely picture. And these are the different waves that are produced from the different chest leads. So you can see V1 is it's kind of a negative deflection here with very little positive deflection. And we're going to see V5 is a very positive deflection, as is V6. So they're all going to look a little bit different because they're taking a picture from different parts of the heart. And this is going to be considered a normal EKG. Again, what we're going to look at is down here on lead 2, do we have a positive deflection for our P waves? And we do. So we can see that our leads are on the right leg. We can see lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, 2, and 3, 4, 5, and 6. That's our 12 lead EKG. So we do need to be able to look at the monitors and identify arrhythmias, because if we're standing there taking a patient history or we're in there while they're doing an EKG, we need to be able to identify these things. So this is considered a normal sinus rhythm, and it is a heart rate between 60 and 100. And so we can see we have a beautiful P wave, a QRS, and a T. We have a little break, a P wave, a QRS, and a T. Notice that all of those between the T wave and the P wave, they're all about exactly the same length, okay? There may be a tiny bit of a deviation, but we're going to be able to see that, okay? Bradycardia is a heart rate less than 60. So you can see we've got our P, our QRS, and our T's, and we have a much longer break here between these, between the QRS segments or the complexes. Bradycardia is anything less than 60, and it's not always bad. In some patients, if you look and their heart rate's normally 88 and all of a sudden it's 50, we may be concerned. But there are people out there who have very low heart rates, athletes, people that exercise regularly. So we need to make sure before we panic, we go back and look at to see what their heart rate has been over the past few visits. Sinus tachycardia is anything that's greater than 100. Sorry, my clock sings to me every hour, so I had to take a little break there. Sinus tachycardia, again, is anything that's over 100 beats per minute. And so when we see this, you can see that the QRS or the complexes are much closer to one another. And we know that that's an increased rate. So there's something else that's called sinus arrhythmia. So we have a heart rate that's between 60 and 100. It can also be a little faster, a little slower. But the interval between the complexes is not the same. So remember when we just saw a normal sinus rhythm, we had the same amount of space between each of the complexes. Here we're seeing a long break, a longer break, a short one, very short. So this is just called sinus arrhythmia. Atrial fibrillation is an irregular heartbeat that actually causes poor blood flow through the body. It can be very, very dangerous. So what's happening during atrial fib? The two upper chambers, the left and the right atria, are beating very chaotically and irregularly. They're not in sync with the AV node and the bundle of His and the bundle branch blocks and all of that. So that SA node's just firing like crazy, but that connection to the AV node is just not right. So what happens is they feel like their heart rate is really, really high. They feel palpitations. They can get short of breath and weak. So these little bumps in here are all of the times that the atria are firing. So these are little P waves. Each one of those P waves, it keeps firing, 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 firing. And then all of a sudden it catches, the AV catches, and we have a QRS, and then we may have some more. And the reason this is so problematic is because the heart is not pumping the blood out like it should. And so if it's pooling in the ventricles or any other part of the heart, we can actually get blood clots. And then the heart pumps the blood clots out, and we can have a lot of problems like thrombosis, mainly stroke as it throws a clot into the brain. It can throw a clot into the lungs. So this is very, very dangerous. Most people, I'm saying most, have some type, who have atrial fib, have some type of medication that's going to be thinning their blood. Some will take Coumadin. Some will do, now there's so many new ones on the market now. Xarelto is one. And so you're going to see that. The nice thing about the newer medications is we don't have to draw blood all the time like we do with Coumadin to make sure we're not making the blood too thin. Atrial flutter is a little bit different. You can see we have these flutter waves, and they're the same in between each of the complexes. So what happens is it's still, the atria are still firing, but they're doing it in a little bit more rhythmic pattern, okay? It's less chaotic. And so what we'll see is we'll see a number of the fibrillation, or the flutters, and then a QRS, then a number of them, and a QRS. So this isn't all over the place. The waves look similar in between, and that's how you differentiate between the difference between flutter and fib. SVT, or supraventricular tachycardia. It is an abnormally fast heartbeat, and it's really caused by the firing, that rapid firing from the AV node. Okay, so it just goes a little bit crazy. So you may not see P waves in front of these. So see, we're seeing a QRS, we're seeing the T, but we're not seeing that P wave. So it's just rapid firing with that ventricle. Oops. Oh, here we go. Hang on. I'm getting ahead of myself. A junctional rhythm it's a cardiac rhythm that has no P wave. It can be a junctional bradycardia as well if it's lower than 60. So you can see, and this is in lead 2, we have a nice isometric break here. We see the QRS, and then we come over and have the T. Then we have that nice break, the QRS, and then the T. So we're not seeing any P waves. Idioventricular rhythm is any type of cardiac rhythm caused by repeating discharge of impulses at a rate of less than 100 beats a minute. And the focus is generally from the ventricles. So it's an idioventricular rhythm. We don't see a P wave. There is no PR interval here because we don't have a P wave. Ventricular tachycardia, or VTach, is an arrhythmia where the muscles of the ventricles contract irregularly in a really rapid, coordinated manner. So we're going to see them in a nice, evenly paced picture on that monitor. But the problem is it impairs the normal pumping of the blood because we're not having any atria pumping into the ventricles. So the atria are just sitting there and the ventricles just pumping, 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 and pumping. Okay. Again, we don't have a P wave because it's just the ventricles that are contracting. And the problem with VTach is it generally leads into VFib, which is not good. VFib, or ventricular fibrillation, this is again where, just like with the atrial fib, it's chaotic impulses in the ventricles. The ventricles are not contracting completely, and what's happening is we're not having blood sent out through the body, through the arteries, so we're not going to have a good pulse, we're not going to have a good blood pressure, because there's really no systemic pumping of the blood through the body. So again, no P wave, no PR interval, and we have no QRS. It is just a mess. It's pretty much just like a quivering. This is life-threatening, and we have to do something when we see this type of arrhythmia. Asystole is the absence of a heartbeat. That is not good. That means that they are in cardiac arrest. Again, just a flat isoelectric line. Now, before you start doing CPR on somebody like this, make sure that their leads are on, make sure that there's not some type of malfunction. If a patient is talking to us and you see asystole, there's got to be something that's going wrong. Generally, when we see asystole, we do begin CPR. A PVC is actually a contraction of the chambers, or of the ventricles, that occurs earlier than usual because of the electrical activity of the ventricles. So you'll see here, we have normal beat, all of a sudden it just decides to do a ventricular beat and early and kind of messes everything up, but then goes right into a normal pattern again. When we look at the bottom one, so we see this PVC, we're going to see a good complex, we're going to see a second good complex, and then a PVC, we're going to see a complex, the second complex, a PVC. And so what they'll do is they'll call this trigeminy, which means every third beat they're having a PVC. If it's every other beat, it's bigeminy. If it's every fourth, it's quadrigeminy. So we look at that to see if there's some type of pattern with that. Heart blocks are a little bit different, and sometimes they can be hard to identify on an EKG. So what the problem with heart blocks is there's no communication between the atria and the ventricles. So there is a major disconnect between that AV or SA-AV node and the bundled His and all those wonderful things. Okay? So a first-degree heart block has a delayed conduction through the AV node, which results in a prolonged PR interval. Okay? So let's go back here for just a second. So we're going to see we've got PR interval, first of all, should not be longer than 0.2 seconds, which is one big box. Okay? This big box is 0.2 seconds. So when we see that PR interval, we're going to see the P wave, and then we've got that break, and then the QRS to the T, all right? So we're going to look right here from the beginning of the P wave to right here before the Q wave fires, okay? So this should not be longer than one box. If that is, that's considered a first-degree heart block. This one's really nice and easy to see. You can see the P wave, we have a very long break. Then the QRS, and then it goes on. Okay, so that is longer than the 0.2 seconds, and that's why it's a first-degree heart block. Second-degree type 1 heart block is called Mobitz 1 or Wenckebach. I love that name. This is almost always a disease of the AV node. And with a Mobitz 1 heart block, it's a progressive, prolonged, being the PR interval being prolonged on consecutive beats, followed by a P wave. Okay, so let's look here. So we have P wave, we have a QRS, and we have the P wave, or T wave. Okay, so now we're starting to see that PR interval is increasingly prolonged. So it's going longer and longer and longer, and then it'll drop a QRS complex. And then the PR interval resets, and then the cycle repeats. So again, we're seeing the P, QRS, the T. We've got the P here. We've got a longer interval, QRS, T. Now, the P is almost on top of the T wave here. We have a much longer interval, a QRS, a T, and then we have the QRS is lost. We start up with a P, QRS again, and we'll see the same repeating pattern. Second degree type 2 is Mobitz 2, and this is usually a disease of the bundle of His and the Purkinje fibers, or it's also called the distal conduction system. Mobitz 2 is the intermittent non-conducted P wave. And so what we're going to see, there's usually a fixed number of non-conducted P waves for every successfully conducted QRS. So there's usually a ratio describing the Mobitz 2 blocks. So let's say there's 2 P waves for every 1 QRS complex. We're going to call that a 2-to-1 Mobitz 2 block. Okay? So we're going to see a P, QRS, T, there's a P, there's a P, there's a P, a QRS, T, a P, a P, a P, QRS. So you're going to see the same number of intervals of your P waves in between a Mobitz 2. Oops, see, I got too excited. Third degree heart block is known as a complete heart block. And this is where the impulse generated in this SA node does not extend to the ventricles. So what we're going to see is just those P waves that are going. There's no PR interval. There's no QRS in sign or time. And there's just no relationship at all between those P waves and the QRS like we see in a normal EKG. So we see a P wave here, a P wave here, and then all of a sudden we have a QRS not associated with that. We have a P wave again, QRS out of nowhere, and then the T wave, and then our P wave and P wave. So there's just no connection with those P's and QRS's. Some different terminology when we look at the segments and intervals. Again, we talked about ischemia. And if we see an ST segment depression, or if the T wave is inverted, instead of a positive deflection, it's a negative deflection, we can look at that and assume there may be some type of ischemia. An injury that we may see is there is an increase in the ST segment. Any type of elevation in that ST segment is considered a myocardial infarction. And you're going to hear the word STEMI, and it means ST segment elevation myocardial infarction. Or ST elevation myocardial infarction. And so if you're working in the ER, you may hear there's a STEMI coming in. And that's exactly what they're talking about. There's an elevation. When a STEMI's coming in, once they hit the door, they have to hit the cath lab within a certain amount of time to hopefully help any type of permanent damage to the heart. A STEMI is diagnosed by greater than 1 millimeter increase in the limb leads or greater than 2 millimeters in the precordial leads. Again, life-threatening arrhythmias that we need to be concerned for. VFib is a life-threatening arrhythmia. We are going to call for help. We're going to start CPR and have somebody grab that AED. VTAC, we recognize it as an arrhythmia. What we're hoping is that it doesn't turn into VFib. We're going to call for help if they're not perfusing, or if it goes into VFib, we can start CPR. But we're also going to get that AED, because the AED may be able to shock the patient and shock the heart back into a normal rhythm. Asystole is a no-brainer. We start CPR, call for help, get the AED. Bradycardia, we're going to monitor our patient. Again, we've talked about this. Athletes, people on digoxin, which is a heart medication, are going to have a slower heart rate. And so if we believe we need to call 911, we can. We're going to stay with the patient until they're transferred. If you are worried about them, if they normally have a high heart rate and they're now down in the 50s, you may want to put them on an AED just in case something happens. And tachycardia, again, we're going to monitor it. If they believe that it is life-threatening or they're worried about something going on, they can contact 911. We're going to stay with the patient until they're transferred. We're talking about outpatient at this time. And again, we may want to put the AED pads on just in case something happens and we can get to the AED quickly. Pacemaker spikes on an EKG, you'll actually see that. So there's ventricular pacers and atrial AV sequential pacers. So these are the pacemakers that are implanted in a patient to try to help. So they actually kind of shock the heart a little bit, okay? So you're going to see that. So see right here, this is going to be your pacer spikes. So what it looks like is happening, that this might be a problem with ventricles firing. So they put in a ventricular pacer. You know, we got a nice P, but we are not following up with a QRS. So the pacer just fires. It'll allow for... Sorry, I had a FaceTime call coming in from Jackson. So anyway, we'll see the ventricular pacers firing to get that ventricle to fire. There's also atrial pacers that we can see. This is actually an atrial and a ventricular pacer. Okay? And that is it. So you just had your beautiful lesson on EKGs, the blood flow through the heart, the electrical conductivity, EKG placements, and arrhythmias.